Welcome. This presentation is on the use of ASV or adaptive support ventilation on our Hamilton ventilators. The objectives of this presentation is to cover what ASV is, the logic behind ASV, the main ASV control parameters. We'll also cover how the targets and limits are defined in basic use and how this mode could effectively be used for many patients. Adaptive support ventilation employs a feedback-based control system where the ventilator constantly evaluates patient parameters like tidal volume, respiratory rate, compliance, and resistance. The ventilator dynamically adjusts inspiratory pressure, respiratory rate, and tidal volume to maintain an optimal minute ventilation while accounting for changes in the patient's condition. It's been asked if ASV is just another mode. ASV really is the beginning of closed-loop ventilation designed to continually adapt to patients' conditions and needs with two main goals. The first goal is for ASV to allow the provider or RCP to simplify all ventilator settings, creating one mode for all patients, whether they're passive or spontaneously breathing. To this end, ASV has just three main control parameters: percent minute volume, PEEP, and FiO2. One mode for all patients means that instead of the RCP having to constantly change modes, ASV transitions the patients from control mode to spontaneous mode as they progress breath by breath until they are ready for liberation from mechanical ventilation. As we see in this graphic, the modes of ventilation are controlled by ASV itself, leaving us as caregivers just three main parameter controls. CO2 elimination controls, such as tidal volume and respiratory rate, as well as breath cycle parameters, are consolidated and controlled by percent minute volume. Oxygen is then controlled by PEEP and FiO2 as usual. We'll start by focusing on control of CO2 elimination with the percent minute volume control in ASV. Minute volume is normalized to ideal body weight. Ideal body weight is calculated into the ventilator by selecting gender and height. At 100% minute volume, this equals the patient's baseline ventilation requirements. This is a patient in normal capnia, at rest, with normal metabolism and normal lung mechanics. As for the control of oxygenation, the PEEP and FiO2 controls functions the same as in any other mode, and your settings would follow the same protocols we use at Peace Health and your own clinical judgment. Now that we've simplified ventilator settings, this brings us to the second goal of ASV, to make ventilation more physiological. ASV achieves this by automatically selecting the breathing pattern and by continuously adapting to changes in lung function. To understand how ASV achieves physiological individualized ventilation, we'll look into the logic behind ASV. When minute volume is set by the operator, ASV first plots the ASV graph seen here. Note that the vertical axis represents tidal volumes and the horizontal axis represents respiratory rate. The minute volume in this example is set to 7.5 liters per minute, and the green dotted line represents the possible respiratory rate and tidal volume combinations that would equal 7.5 liters per minute. After ASV plots this graph, it will then come up with the exact target, which we'll discuss shortly. For the selection of breathing pattern and respiratory rate, ASV focuses on workup breathing and lung mechanics, specifically the difference between a normal lung, an obstructive lung, or a restrictive lung. To do this most accurately, ASV uses the Otis formula. The Otis equation itself is complex, as you can see here. However, to grasp the concept simply, look at the factors in the equation, such as time constant, alveolar ventilation, and dead space ventilation. And now look at it here, simplified, and you'll see that it uses time constants and lung mechanics to determine the respiratory rate that will generate the least work of breathing. Now let's take this opportunity to dig into and review the concept of the respiratory time constant that I just mentioned. The respiratory system time constant reflects the speed by which the system changes its volume in response to a change in applied pressure. You'll also note that the symbol for time constant is the equation for time constant, RC, or resistance time constant. The associated graph here shows the respiratory time constant can be applied to the inspiratory cycle and the expiratory cycle, with a total of 3 times constant to achieve complete inhalation or complete exhalation. Here we're looking at the flow waveform and the portion of the breath that with their corresponding time constants. RC insp and RC exp are monitored values for the inspiratory and expiratory time constants. The normal value for RC exp is 0.6 seconds to 0.9 seconds for the normal lung. As we stated, the value range is 0.6 to 0.9 seconds. Looking to the left, we see the restrictive lung in blue shows a range of below 0.6 seconds. This is a short time constant, which makes sense because restrictive lungs fill and empty faster. To the right, we see the obstructive lung in red showing a range of above 0.9 seconds, which is a long time constant, which also makes sense because obstructive lungs fill and empty slower. The expiratory time constant, or RCX, is obtained from the expiratory flow volume curve, and it can be estimated on a breath-by-breath basis. In this prospective observational cohort study of passively ventilated patients, ASV delivered different tidal volumes and respiratory rate combination based on the underlying condition, specifically providing lower tidal volumes in ARDS than in COPD. Here, we show the monitoring of the ventilator demonstrating a patient with an RC-exp in the normal range and the corresponding rate and mils per kilogram value for tidal volume. In this patient, the monitoring of the ventilator demonstrates an RC-exp in the short range, indicative of a restrictive patient, and the corresponding rate in mils per kilogram value for tidal volume. And now we can see the monitoring of a patient demonstrating a ventilator demonstrating a patient with an RC-exp in the long range, indicative of an obstructive patient, and the corresponding rate in mils per kilogram value for tidal volume. And finally, again here we're showing the monitoring of a ventilator demonstrating a patient with an RC-exp in the extremely prolonged range. Since its introduction, there has been improvement to the ASV software, notably the addition of the Mead equation. The Mead equation determines the least force of breathing, which achieves the least driving pressure, and also equates to the selection of a lower average mil per kilogram tidal volume value. This keeps ASV in sync with current standards in the ICU regarding appropriate tidal volume strategies. The Mead formula has two elements in common with the Otis formula, notably alveolar ventilation and dead space ventilation, as well as the RC-exp or expiratory time constant. The Mead formula again focuses on achieving the least driving pressure, which equates to lower average tidal volumes. Now that we understand the Otis and Mead formulas a bit better, let's look at how ASV determines the target values and value limits for each patient. To review, the user defines ideal body weight by placing the correct gender and height values in the standby screen. ASV then uses that ideal body weight to calculate dead space and generate a basal ventilation requirement expressed at 100% minute volume. The user then controls the target percent minute volume based on patient condition and PCO2 targets. ASV continually assesses the patient condition. Once the caregiver sets the target percent minute volume and PASV limit, ASV then delivers 3 test breaths while monitoring the lung mechanics and spontaneous effort. This then translates to the calculation we covered before, the Otis and Mead equation, which results in ASV defining tidal volume and respiratory rate targets individualized to the patient's lung mechanics. This algorithm then automatically adapts on a breath-by-breath basis. Having the ASV algorithm respond to changes in lung mechanics and spontaneous patient activity on a breath-by-breath basis creates a closed-loop control. Now let's look back to the ASV graph, one of the graphic options on Hamilton ventilators in ASV mode. This graph can help you understand how targets and limits are being defined by ASV. Here we show a patient with an ideal body weight of 66 kilograms, which generates a target minute ventilation of 6.6 liters per minute at a setting of 100% minute volume. In this example, ASV has run its algorithms, including monitoring the RCX at 0.67, which is normal phase, then generated a target respiratory rate of 16 and a tidal volume of 424, which happens to be 6.4 mils per kilogram of ideal body weight. To achieve these target values, ASV first defines its limits by creating a safety window on the ASV graph. To think of it simply, as ASV takes the pulmonary mechanics displayed and the dynamic lung graphic, it creates a graphical representation of those lung mechanics overlaid on the ASV graph. This results in the ASV safety window, which aims to define limits for respiratory rate and tidal volumes that avoids baro and volume trauma, auto PEEP, dead space ventilation, and apnea. This safety window is displayed on the ASV graph as the red box. The target respiratory rate tidal volume combination target is represented by the circle. The patient's current actual values are represented by the yellow cross. If the patient's spontaneous activity exceeds or falls short of the defined targets, then ASV will make the breath-by-breath adjustments. These breath-by-breath adjustments are explained by looking at the ASV graph itself. Any movement of the yellow cross away from the target circle is met with a corresponding response in pressure support and mandatory respiratory rate. The safety window itself also indicates the patient lung condition. With normal lung mechanics, the safety box will be relatively square. Now here we see a restrictive lung with a short expiratory time constant, which results in a safety window that is short and wide, indicating a lower tidal volume range and a higher respiratory range within the window. Here we see an obstructive lung with a long expiratory time constant. This results in a safety window that is tall and narrow, indicating a higher tidal volume range and a lower respiratory rate range within the window. Now we've truly become ventilation geeks, haven't we? And we've explained how complex and sophisticated ASV really is. But right now, let's take a step back and realize how simple ASV is to use for the caregiver. When selecting the patient, make note that the two absolute contraindications are non-invasive ventilation and the presence of a bronchopleural fistula. Both of these are not conducive to achieving the closed loop ventilation. The relative contraindication of irregular respiratory drive could be present in a neurostorming patient, a DKA patient, or any other metabolic sepsis patient. Next, we must have the correct gender and height and enter it into the ventilator in order to achieve the correct ideal body weight settings. Gather this information, select the patient group, and then enter the ideal body weight. Setting the percent minute volume. So for passive breathing patients, this setting will create the target and actual minute ventilation. You can increase or decrease this setting in increments of 20% if increasing, or 10% if decreasing to reach the target PCO2 value. When initiating mechanical ventilation, start the patient at a value of 100 to 110% minute volume. For spontaneously breathing patients, the percent minute volume will function as the minimum minute ventilation. The patient can go above this minute ventilation, but cannot go below it. Adjust the percent minute volume in a spontaneous breathing patient to increase or decrease the level of pressure support delivered and to increase or decrease the mandatory rate. PEEP and FiO2 in ASV is no different than any other mode. Set these according to objective patient data, our facility's protocol, and your own clinical judgment. These other settings will help ensure patient synchrony, especially in spontaneously breathing patients. These settings are standard synchrony settings that allow you, as a caregiver, to individualize ventilation further. Begin with the default settings for the patient population and adjust based on patient's response and analyzation of waveforms. Set the flow trigger setting to avoid missed efforts, but also to avoid auto trigger. Your standard settings apply. Set P-ramp, which stands for pressure ramp, shorter to alleviate flow starvation or longer to avoid pressure spikes on inspiration. Set ETS, which stands for expiratory trigger sensitivity, higher for patients with obstructive diseases and lower for patients with restrictive diseases. The PASV limit can be set to achieve a pressure limitation, and it is linked to your pressure alarm by 10 centimeters of water, which, in this example, a PASV limit of 30 will set the pressure alarm to 40 centimeters of water. As you can see, it is quite easy to initiate and adjust ventilation with ASV during initiation and stabilization, as well as escalation or de-escalation of care. Once a provider starts de-escalation cares, we can begin to utilize the weaning tools of ASV. We can begin to utilize the weaning tools of ASV when weaning. We still follow our facility's protocols for assessing weaning trials and extubation options. However, with ASV, you have tools at your disposal that can offer you, as a caregiver, the objective information needed to safely execute our facility's protocols. The main tool in your disposal is the vent status screen. The vent status screen shows all 6 parameters of the criteria that the patient must meet successfully in order to achieve a safe and effective spontaneous breathing trial. The upper and lower limits of each of the 6 parameters are defined by our facility's protocols and can be programmed into the ventilator. The silver bars represent the patient's monitored values, and when the patient meets one of those 6 criteria, the silver bar then rests between the upper and lower limits. A clock then appears at the bottom of the parameter, which counts in minutes as long as the patient remains in that goal zone. Here you can see the patient is meeting 4 out of the 6 parameters. This would represent the patient who is in the screening phase for weaning. This example represents a patient who has just become ready to wean. We can now see that the patient has met all 6 parameters successfully, engaging all 6 clocks, so that we now have a green master clock counting in minutes for as long as the patient continues to meet all 6 criteria. We now see that the same patient has met all criteria for a total now of 3 minutes. Please note, due to the caregiver not needing to adjust modes of ventilation in practice, a patient set at 100% minute volume who meets all 6 criteria can successfully begin weaning with no effort on the part of the caregiver. Remember, ASV is one mode for the entire course of ventilation. In this situation, in order to fully prove the patient can successfully extubate on ASV, you have the option of either dropping the percent minute volume from 100 to 70% or dropping percent minute volume to 25% as shown on this screen. Please note that if you choose to drop a percent minute volume to 25%, the caregiver should then remain at the bedside. This is due to the minimum minute ventilation being 1.7 liters at 25% minute volume, which is not sufficient should the patient become apneic. During this period, whichever example you choose, extubation is acceptable if the patient is meeting all 6 criteria and meeting all our facilities requirements for extubation at any percent minimum value below 100%. Before we wrap up, I'd like to go over some troubleshooting tips and additional device features. Due to the location of the flow sensor, there is an increased chance that water or secretion can cause sensor disturbances. To help reduce this, keep the flow sensor upright to minimize the risk of water or secretions getting aspirated into the blue or clear pressure lines. Also, if there is a flow sensor alarm, remove the patient from the ventilator and clean or replace the sensor. Be sure to recalibrate or calibrate the sensor before placing the patient back on the ventilator. In the event of a flow sensor and disconnect alarm, clean or replace the flow sensor and verify the circuit and/or pressure lines are all appropriately connected. We just learned how great ASV can be for those patients in respiratory failure, from intubation to extubation. But let's not forget all the other modes that this device is capable of. Just as any other manufacturers have proprietary names, so does Hamilton. Take a look at this chart. As you can see, the Hamilton can do everything most other ventilators can, just by a different name. Here at Peace Health, we default to the Puritan Bennett, and as you can see, APCMV is the same mode as ACVC, and PCMV is ACPC. The two devices are able to provide the same ventilatory support for all patient population. This concludes the presentation on ASV ventilation for Hamilton Ventilator. Thank you for participating in this education. Please ask your clinical educator if you'd like additional resources regarding ASV ventilation or hands-on learning on the Hamilton device.